Associate Editor for Journal of Internal Medicine Research, is also on the chair of RGHS. He has multiple accolades to his credit, multiple publications, and also is one of the founding members of Viva Foundation. He is instrumental in conducting the activities, the scientific activities, and because of his guidance and thought process, we are here to have the 6th edition of Annual National Conference of Viva Foundation FEFCON 2023. Nagaraj sir, thank you very much for all your support, guidance, and to chair the session. It's over to you, sir, to conduct this session.
Thank you, Dr. Krishna. Good morning, everybody. This is a very much awaited session. It's Clinico Pathological Conference, and since morning we are hearing all the chief discussers who are telling battery of investigation, battery of panel of IgG, IgM, so many investigations. In spite of all that, clinical examination and clinical analysis is the most important thing. And to reflect that, we have got this Clinico Pathological Conference. And I am very happy to introduce Dr. Shrikant Hegde. Dr. Krishna, can you put Dr. Shrikant Hegde's this one slide, please?
It's coming. It's on. It's on.
Dr. Okay, first I will introduce.
Previous slide.
Yeah. Okay. This case protocol will be discussed by our physician friend, Dr. Shrikant Hegde. Dr. Shrikant Hegde did all his MBBS and MD from KMC Hubli, and is a consultant physician at Shivamogga, Karnataka for a long time. And he is the former vice chairman of APA Karnataka chapter. And right now he is the editor-in-chief of APA Journal of Internal Medicine, one of the very, very recently well-recognized journal of our state and also to the country. And he has got 13 publications in index journals and a reviewer of multiple journals. And also he was faculty of Epicons in 19, 20, 22, and continuously delivering his talks in Epicon. And his hobby is photography. When I invited him to discuss this case, actually he was traveling for 15 to 20 days out of the country. In spite of this busy schedule, he agreed to discuss this case. And I'm very, very happy for that. I invite Dr. Shrikant Hegde. And next, I want to introduce Dr. Vijaya. Madam is a professor of pathology at JSS Medical College Hospital and at Mysore. And she has got 27 years of teaching experience in pathology and multiple publications, more than 45 publications to her credit. And she's a reviewer for various national and international journals. And she's actually heading the Department of Pathology in JSS Medical College. She has conducted CMEs and delivered multiple guest lectures. And she has conducted CPCs. And while I requested for the protocol, and it's very difficult. Many pathologists were reluctant because one of the components for the protocol would have been fever. Fever should be a component. Then only we can discuss that in this forum. And in spite of the difficulty, Madam agreed, and she is discussing this protocol today. And I invite her also, Dr. Professor Vijay. Welcome to you, Madam. First, what we will do is Dr. Shrikant Hegde will discuss the protocol. Afterwards, Madam is going to give her final diagnosis. Now, I invite Dr. Shrikant Hegde to be Sherlock Holmes to unravel the details, the diagnosis of what Madam has given, our protocol, CPC protocol. Dr. Hegde, please.
Is the slide visible?
Sir,
is my screen visible?
This one, sir. Yeah, slide is visible, but put in this one, sir, presentation.
Right, okay. Thank you, Professor Nagaraja, for the kind introduction. At the outset, I thank the organizers of this fever conference for inviting me to discuss this case. Clinico-pathological case conferences are generally interesting because the cases which are discussed in CPCs are well worked up cases, and most importantly, they would have reached some diagnosis, either by way of autopsy or by way of biopsy. A definitive diagnosis would have been made. And for the clinician, at the end of the discussion, when we get the final diagnosis, there is a clear opportunity to understand whether about our analytical skills as well as diagnostic skills. And if we have went wrong, there is a very good opportunity to reflect upon ourselves where we went wrong, and especially in the thought process or some of the clues which we missed in the case. So that way, clinical pathological case conferences are good learning experience. And I'm happy to discuss this case, which is given to me by Professor Vijaya. The case, I will first discuss about, go in detail about the case, and then I'll come to the discussion part. William Osler said, humanity has but three great enemies: fever, famine, and war. Of these, by far, the most important would be, the most terrible is fever. We are in the fever conference today. Amongst when the world is facing some kind of war and our state is facing famine, these words of William Osler are valid even today, that fever remains an enigma despite availability of lot of investigations and advances in medical knowledge. And this case highlights this statement of Osler. This is a case of 58-year-old male who was admitted for fever and joint pains and abdominal pain of 1 week duration. He had anorexia, fatigue, and pain in the limbs. On examination, the patient was getting temperature of about 39 to 39.6 degrees centigrade. And 2 days later, he developed testicular swelling. There was no dysuria, there was no hematuria, lymphadenopathy, or rash. The patient had significant past history that he had pulmonary tuberculosis and he had completed anti-tubercular drug treatment. He had persistent cough with scanty sputum, for which he was evaluated once and AFB was negative, and no further treatment or investigation was done for that symptom. He also had past history of hepatitis B infection. He was found to be positive for hepatitis B surface antigen 12 years ago. At that time, his hepatitis B DNA was negative. In the last 12 years, he was undergoing serial monitoring for his alpha-fetoprotein levels and ultrasound examination repeatedly. Ultrasound showed simple hepatic cysts. 3 years before the present admission, he was evaluated probably for his respiratory symptoms, and a chest X-ray done at that time showed a nodular opacity in the right apex, and the CT chest done subsequently suggested a calcified granuloma with bronchiectasis. The patient was a chronic smoker for nearly 40 years. He consumed moderate amount of alcohol. There was no family history of pulmonary, ocular, or rheumatological diseases. On examination, the patient was febrile. His vitals were normal. He had blood pressure of 126/68. He had a heart rate of 76, and his oxygen saturation was 97% while breathing room air. The patient had no signs of anemia, rashes, or jaundice. And on examination of the respiratory system, he has faint trails on the lung basis. There were no murmur or there were no lymphadenopathy. Throat examination showed no erythema, no exudation, no rashes, and his bowel sounds were normal. Neurological examination also showed no significant findings. His abdomen was soft. There was no organomegaly, and the abdomen was not distended. An X-ray of the lumbar spine shows multi-level degenerative disc disease, more in L4 and S1. Surprisingly, the clinical examination of the scrotum and testis are not available in the case description. Several investigations were done after admission. His chest X-ray showed persistent opacities at lung bases and apex. The CT scan done of the abdomen showed scattered subcentimetric hypodensities in the liver, which are considered as simple cysts, and he had bilateral small pleural effusion and traces of ascites. Subsequently, few days later, a repeat CT examination showed there was increase in the pleural effusions, and the fluid tapping was done, which showed transudative fluid, which was negative for gram stain, negative for AFB, and bacterial and fungal culture. Meanwhile, the patient continued to develop continued to have fever, and the swelling and the pain in the left scrotum increased, and along with tenderness of the left scrotum. His urine showed 2+ for blood and 10 to 20 RBCs. His ultrasonography of the scrotum showed new engorged testicular vessels, and the features were considered as suggestive of epidermoorchitis. ECG showed sinus tachycardia and few atrial ectopics. Troponin I, creatinine kinase, lipase, LDH, PSA, TSH are all normal. The urine, blood culture, and pleural fluid cultures were sent. CBC showed hemoglobin of 12.6 gram, total leukocyte count of 19,700 with polymorph 78%, lymphocyte 7.4%, monocyte 11.9%, eosinophil 2.6%. His platelets were 3.6 lakhs per cubic millimeter. Hematocrit was 34.9. His urea was 23 milligrams and creatinine was 1.23 milligram percent, which comes to, in a 58-year-old man, GFR comes to around 65. Plasma glucose is 120 milligrams per deciliter. The LFT showed bilirubin of 0.5, serum albumin of 2.7. Total protein and globulins are not mentioned. AST was 57 and ALT was 73, slightly elevated. Lactate levels are normal. PT-INR was 1.4. Fibrinogen was 725 milligram per deciliter, which was high. CRP was 144 milligram per liter, which was high. ESR was 93 millimeter in first hour. Haptoglobin was 453 milligram per deciliter, which was high. Urine examination showed blood 2+, ketones were negative, nitrate was negative, protein was negative, RBCs were 10 to 20, leukocytes were 0 to 2. Blood culture yielded no growth, Legionella antibodies were negative, heterophile antibodies were negative, HIV was negative, antitrypanosomal antibodies were negative, Epstein-Barr virus DNA by PCR was negative. His hepatitis B markers, HBsAg was negative, HBs antibodies were negative, HBe antigen was negative, HBe antibody was also negative, HBC core antibody was positive, and HBV DNA was also negative. His HCV antibody was negative, as well as HCV RNA by PCR was negative. His Brucella IgM and Brucella IgG both were negative. His mumps antibodies, IgM was less than 1.2, which was considered as negative, and mumps IgG was positive. He had ANA positivity at 1:40 dilution and 1:160 dilution, which was speckled. RA factor was negative. Anti-CCP was negative. C3 was normal at 131. C4 was normal at 21. Cryoglobulins were not detected. ANCA was negative. Antinuclear cytoplasmic antibody was negative. Serum protein electrophoresis was normal. Benzone protein in the urine was negative. Urine culture yielded no growth. Blood culture yielded no growth. Stool examination showed no ova or parasites. And at this stage, a diagnostic test was performed. This is in brief the case, which is the protocol of the case, which I'll be discussing in the next few slides. So put the case summary in a nutshell. In history, we have a 58-year-old man who presented with fever and testicular pain, along with constitutional symptoms like fever, joint and muscular pain. He had significant past history of tuberculosis some years ago, for which he was evaluated, and he had past history of hepatitis B virus infection, which was detected 12 years ago. On investigation, the positive findings were the patient had significant leukocytosis with WBC count of 19,700 and ESR was 93. He had microscopic hematuria, 10 to 20 RBCs were seen in the urine, and radiologically, he had persistent lung opacities in the upper lobe, both on CT scan as well as chest X-ray. CT scan showed evidence of granuloma, healed granuloma, and he had pleural effusion, which was tapped, which was minimal and suggestive of transudate, which was negative for infections. His USG was suggestive of epididymoarchitis. Patient was negative for ANCA with mild positivity for ANA, and extensive workup for infectious diseases were negative. This is in summary, the case detail summary of this patient. Now, to approach this case, let me begin whether it is a simple case of single organ involvement or multiple organ involvement. When we see a patient who presents to us with fever of few days duration, which is an acute fever in this case, it's less than a week, and presented with testicular swelling and pain, the common diagnosis which comes to our mind is epididymoarchitis. Is it as simple as in a case of epididymoarchitis, or are we dealing with a systemic illness and epididymoarchitis is a part of that illness? Obviously, when a case is being discussed for CPC, it will not be a simple case of epididymoarchitis. It has to be a different etiology. So what are the systems involved in this patient? A genitourinary system in the form of testicular and epididymis involvement. There is some evidence of pulmonary involvement because patient had old tuberculosis. There was some evidence pleural effusion. Patient had symptoms of cough, for which he was evaluated 3 years ago. And there is some evidence of renal involvement in the form of microscopic hematuria. There is musculoskeletal involvement, like patient had muscular tenderness, patient had joint pains, non-specified. and doubtful involvement of gastrointestinal system, because the case history starts with history of fever along with joint pains and abdominal pain. However, in the further part of the history or examination, there is nothing to suggest an abdominal involvement except for mild elevation of liver enzymes. So obviously it's a multi-system involvement, and testicular involvement in epididymis is a part of it. But let's start with, because that is the most obvious finding for which the patient presented, that fever, then developed testicular pain, and fever increased, testicular pain and swelling increased during the hospital stay. I would like to consider a possibility of testicular pain and swelling as a first thing. Swelling of the epididymis and testis is or it may be commonly due to inflammation of epididymis and testis, which we call as epididymoarchitis. The common causes for epididymoarchitis are infections, vascular causes, trauma, mechanical lesions, and sometimes can be tumor, testicular swelling especially. So I would like to deal with the differential diagnosis of fever and testicular pain. Obviously, when the patient has fever for some days, along with leukocytosis, our focus shifts towards infection, because infections are by far the most common cause for fever. And the patient presented with an acute fever with leukocytosis and high ESR. Several infections can cause epididymoarchitis. Most common of them would be bacterial infection. In young individuals, sexually transmitted diseases like gonorrhea or chlamydia infections are very common, whereas in elderly individuals, especially with those with enlarged prostate, E. coli infections can cause epididymoarchitis. And in men who have sex with men, E. coli infections are common. Brucella infections are common, which commonly can cause epididymoarchitis. Tuberculosis, of course, as the patient also had a history of tuberculosis, can be an etiology for epididymoarchitis. And several viral infections, most importantly, mumps, could be a cause for epididymoarchitis. Let's see one by one which fits into this case. The common infections in young individuals, Neisseria gonorrhea and chlamydia trachomatis are common sexually transmitted diseases. And in older individuals, as I said earlier, especially with enlarged prostate, E. coli can be the causative organism. Generally, when whether it's gonorrhea or chlamydia or an E. coli infection, the patient starts with urethritis. The condition starts with urethritis, and after urethritis, it progresses to epididymoarchitis. The patient presents with urethral discharge, dysuria, and leukocytosis, high CRP and ESR may be seen in such individuals. But our patient had no evidence of urethral discharge. There was no complaints of dysuria. The urine examination showed no pus cells in the urine. Urine cultures were negative. Anti-treponema antibodies were also negative. However, there is no definite evidence of being tested for Neisseria gonorrhea or chlamydia trachomatis. Those investigations are lacking. And I may presume that because the patient was hospitalized with fever, leukocytosis, and testicular pain, he would have received some antibiotics during his stay in the hospital. And because he continued to have fever as well as continued to have increased testicular pain and swelling, probably there may not be response to sufficient antibiotics. Common infections like E. coli infections or Neisseria gonorrhea could have responded to common, and which are commonly thought when we suspect a case of, when we see a patient with epididymoarchitis and treat. As the patient has not responded during the hospital stay, probably there may be this infection or his condition is not responding to antibiotics. It's a presumption. Then another important condition with differential diagnosis we consider in a male with these symptoms is brucellosis. Brucellosis, as we know, is a great mimicker. It can mimic several conditions, and testicular and epididymal involvement can be seen has been reported in several case series, with the incidence ranging from 6% to 10%, depending on the studies. And they can present with fever, joint pains, and muscular pain. They can have high WBC count, ESR may be elevated, CRP may be elevated. Orchitis has been reported as a common manifestation of one of the common manifestations of brucellosis when it involves the testis. They can present with orchitis, they can present with necrotizing orchitis, testicular abscess, and even case reports of testicular mass from mimicking tumors have been reported, which was finally confirmed as cases of brucellosis. However, the patient was tested for brucella his IgG, mainly by serological tests, IgM and IgG Brucella antibodies are negative, and his blood culture was also negative. Probably Brucella goes lower down in the list. Mumps orchitis comes as a differential diagnosis for testicular swelling and pain and fever in an adult. Usually, mumps orchitis happens when within a few days or weeks after parotid swelling, when the patient develops mumps infection. Sometimes, rarely, testicular swelling may precede parotid swelling. However, this patient never had parotid swelling either before presentation or during his stay in the hospital. There was no, and his IgM antibody negative, which would have been positive in cases of acute mumps, is negative here. And his IgG is positive, suggesting that either the patient had past infection with mumps or he has been vaccinated for mumps. So mumps orchitis goes down in the list of differential diagnosis. Now I come to the most important differential diagnosis which I consider in this case, which is tubercular epididymoarchitis. Tuberculosis of genitourinary tract is one of the common form of extrapulmonary tuberculosis. May not be the most common, but one of the common forms of extrapulmonary tuberculosis. Generally, it is the retrograde extension from prostate or seminal vesicles, or it can be a part of renal tuberculosis. 50% of the patients with renal tuberculosis may have some extension to epididymis and testis. Epididymis is affected first and testis may be involved later. This patient had past history of tuberculosis. He had some respiratory complaint which was ongoing, and he had high ESR, high CRP. However, generally, tubercular epididymoarchitis is subacute or chronic. Generally, it starts as less acute condition, presents with painless testicular enlargement or painless epididymal enlargement initially, and gradually it might be. However, there is no rule as such. It can present with acute presentation. All evaluation done like sputum examination, pleural fluid examination, and cultures were negative for tuberculosis. There were no pus cells in the urine. Suppose if there are pus cells in the urine and the culture was negative, we would have considered renal tuberculosis as a possibility. However, that was not there. There is no report of probably in this patient, CBNAT for of the urine could have been helpful to detect or rule out genitourinary tuberculosis, especially renal tuberculosis. The ultrasonogram shows generally in cases of tubercular epididymoarchitis, non-homogeneous epididymis with hypoechoic areas in the testis, and its epididymis might show beaded pattern. Here, the clinical examination would have been important to suggest if the patient has beaded epididymis or whether it is mainly testicular swelling or epididymal swelling. In the absence of clinical examination of the testis, I would go mainly by the ultrasound evidence, which does not show the features of tuberculosis as in the form of non-homogeneous epididymis or hypoechoic areas in testis. However, increased vascularity may be seen in tubercular epididymis on Doppler ultrasound. Generally, it is secondary to hematogenous spread or spread from neighboring tissues. Here in this patient, there is no evidence of reactivation of pulmonary tuberculosis. His 3 years back when he was evaluated, the CT showed a healed granuloma, and the X-rays and CT scan done in the present admission also showed only persistent shadows. His sputum was negative, and primary tubercular epididymoarchitis is rare. However, in a patient who had already had tuberculosis once, clinically and with this investigation, it is difficult to rule out TB epididymoarchitis. I would keep this as one possibility in this patient. What I do not understand is this acute presentation, the systemic involvement, elevation in all anti-inflammatory markers, presentation, acute systemic illness in the form of even developing pleural effusion, so which is not exudative, which is transudative, suggesting an acute inflammatory process. So this acute presentation is something which does not fit into tubercular epididymoarchitis. However, we cannot rule out based only on this fact. There are less common causes. However, they need to be ruled out, especially in a patient with testicular pain and swelling and fever. One of them is a surgical emergency, that is torsion of the testis. Torsion of the testis is a condition which happens in infants, children, or young adults. And in this man of 58 years, torsion is very unlikely because the patient had symptoms for a few days. Generally, it's an very acute condition requiring immediate surgical attention. And ultrasonogram in torsion of the testis shows transversely placed testis with absent or decreased blood flow on Doppler. On the contrary, the ultrasound in this case showed engorged blood vessels and increased blood flow. So torsion is very unlikely in this patient. And as there is no history of trauma, we can safely exclude trauma as a cause. Testicular tumors can be considered as a differential diagnosis for painful and for testicular enlargement in an adult. Generally, they are painless swelling unless there is hemorrhage or infarction into the tumor. Raised beta HCG of alpha fetoprotein and ultrasound features are distinctly different. That would have shown a heterogeneous enlargement of the testis or hyperechoic areas or hypoechoic areas in the testis, non-uniform enlargement of testis. So, but one condition which can be very difficult to diagnose is primary testicular lymphoma in an adult. But primary testicular lymphoma, though rare, is a painless testicular enlargement, as this patient had and the constitutional symptoms of fever and acute inflammation generally are not present in cases of testicular lymphoma. So we can reasonably rule out testicular tumors as a differential diagnosis in this patient. Now we are left with vascular causes for epidermolysis in this patient. We come to possibly vasculitis. Testis is a highly vascular organ, and it can be a part of several systemic vasculitis. Vasculitis are a group of disorders where blood vessels are inflamed with maybe autoimmune origin or some unknown etiology. The vessel walls and the vessels are infiltrated with inflammatory cells. So when there is inflammation and infiltration of the vessel, there is obliteration of the vascular lumen, which results in decreased blood supply to the organ supplied by the vessels. So the clinical manifestation depends upon the vessel involved, and it's a systemic vasculitis. There can be local vasculitis also. So when we consider vascular involvement, does vasculitis fit in this patient? Systemic vasculitis this patient has a multi-system problem. It's a systemic problem. It's an inflammatory condition with elevated inflammatory markers. CRP was 144, ESR was 93, heptoglobin was high, and fibrinogen was high, albumin was low, which is a negative marker. So all those things suggest that we are dealing with an inflammatory condition, with a systemic inflammatory condition, and an extensive workup for infective etiology offered no clue. Testicular involvement is common in some form of vasculitis, and there is USG evidence shows engorgement of testicular vessels, pointing towards the possibility of a vascular involvement. So with this in mind, I come to the vasculitis as a differential diagnosis for this patient. A brief, one slide about the vasculitis, classification of vasculitis. Generally, it is classified based on the vessels involved. There is large vessel vasculitis, which involves aorta and its major branches. There are two main conditions in this: giant cell arteritis and Takayasu arteritis. Medium vessel vasculitis, which includes polyarteritis nodosa and Kawasaki disease. Small vessel vasculitis, which includes several vasculitis, which are ANCA-associated vasculitis, IgA vasculitis, and conditions like cutaneous leukocytoclastic vasculitis and cryoglobulinic vasculitis. ANCA vasculitis is a small vessel vasculitis with the positivity of ANCA, anti-nuclear cytoplasmic antibody, which includes three main conditions like granulomatosis with polyangiitis, previously called as Wegener's granulomatosis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis, which was previously called as Church-Strauss syndrome. Now let's see which type of vasculitis fits. Generally, testicular artery is a medium-sized artery. However, in vasculitis, there is no hard and fast rule that is mid-sized vasculitis, middle-sized artery vasculitis may involve small arteries also, and small vasculitis may sometimes involve middle-sized arteries also. But let's see one by one. Large vessel vasculitis, there are two important conditions: giant cell arteritis. Giant cell arteritis presents in elderly above 60, but generally not below the age of 50 years. And it may present with severe headache, sometimes with visual symptom, and jaw claudication, tenderness of the temporal artery, high ESR, body ache, musculoskeletal symptoms. However, this patient had no symptoms of headache, visual symptoms, or there was no history suggestive or examination findings suggestive of temporal artery tenderness. ESR was seen, but because the giant cell arteritis generally involves upper branches of cranial arteries and the head and neck, and other features are not present in this patient, we can exclude giant cell arteritis reasonably. Takayasu arteritis, of course, it doesn't fit into the present clinical picture of this patient. which is seen in younger individual, mainly involves aorta and its branches. Clinical features include claudication, differences in the pulse, differences in blood pressure, angina, and absent peripheral pulses. So this condition can be very well excluded in this patient. There are several small vessel vasculitis which need to consider before we make a final diagnosis in this patient. Small vessel vasculitis like vaginous granulomatosis presents with predominantly respiratory and renal involvement, destructive upper airways, ears, cartilages of the ear, nose, and they can present with multiple lung shadows, cavitatory lesions in the lung, etc. And it also presents with significant renal problem in the form of glomerulonephritis, rapidly progressing glomerulonephritis, and renal failure. 90% of the cases are positive, especially when the disease is active. Lung opacities and high inflammatory markers were seen in this patient. However, these lung shadows were stable and they were attributed to old infection. There was no increase in the lung shadows or no new shadows which appeared, and there was no evidence of any destructive lung lesions in the form of sinusitis or earlobe damage, arthritis, nephritis. And the patient was ANCA negative in this case. So unlikely to be a case of granulomatosis with angiitis or with polyangiitis or vaginous granulomatosis. So we can, the next possibility is ANCA, small vessel vasculitis is Church-Strauss or eosinophilic granulomatosis with polyangiitis. This is similar to the previous condition, but the significant difference is there is peripheral and tissue eosinophilia. Patients present with asthmatic episodes, skin rashes, urticaria, and pulmonary infiltrates, mononeuritis multiplex, myocarditis, and various skin lesions can be seen. Eosinophil count more than 1,000 is a significant finding, along with high ESR and CRP, and at least 50% of the cases ANCA will be positive. In this patient under discussion, there were no asthmatic episodes, no skin lesions, no pulmonary infiltrates, and eosinophil count was only 2%. So, and it was ANCA negative, unlikely to be a case of Church-Strauss. Microscopic polyangiitis is another small vessel arthritis which presents similar to GPA, but except that the upper airway and pulmonary nodules are not seen, it predominantly involves the smaller capillaries and venules of the lungs and liver, lungs and kidney, presenting with pulmonary hemorrhages, hemoptysis, and even glomerulonephritis and rapidly progressing glomerulonephritis. 75% of the cases are positive for ANCA. Absence of pulmonary hemorrhage, absence of significant glomerulonephritis, and negative ANCA in the present case, significant and without significant respiratory or renal involvement, microscopic polyangiitis is reasonably unlikely in this patient. We all know the common condition IgA vasculitis or Henoch-Schönlein purpura. Testicular involvement may be commonly seen in these patients. It's a triad of rashes in the lower limb, abdominal pain, and arthralgia, common in children but can be seen in adults also. Fever is not predominant symptom in IgA vasculitis. It can have mild glomerulonephritis and RBC casts in the urine. Our patient had no casts in the urine. Mild leukocytosis and IgA is elevated. In the absence of significant rashes in the lower limb and in the absence of other findings, like he had abdominal pain, however, it was not specified and further details are not available. In the absence of rashes, typical rashes in the lower limb, and in the absence of glomerulonephritis and RBC casts, IgA vasculitis may be unlikely in this patient. Of course, cryoglobulinic vasculitis is one where there are cryoglobulins in the blood which are associated with vasculitis. Cryoglobulins are cold-sensitive immunoglobulins, which may be secondary to several infections like hepatitis C virus or multiple myeloma or some connective tissue diseases. And these present similar to IgA vasculitis in the form of palpable purpura, arthralgia, or neuropathy and glomerulonephritis. So patient was tested for cryoglobulins, which was negative. He was tested for hepatitis C, which was negative, and serum protein electrophoresis was also normal. Cryoglobulinic vasculitis also is unlikely in this patient. Now we are left with only two conditions among vasculitis, excluding some of the minor causes like drug-induced vasculitis or rheumatological conditions associated with vasculitis, for which there is no evidence or no history in this patient. We are left with the two important conditions of medium vessel vasculitis. Kawasaki disease is a disease of children, especially below 5 years of age, with significant coronary artery involvement. And they also present with mucocutaneous lesions and lymphadenopathy, which is a self-limiting disease, but may present with aortic aneurysms or even coronary aneurysms at a later age. So in this age patient of 58 years, this is a diagnosis which can be safely and excluded. Polyarteritis nodosa is a medium vessel vasculitis, which involves medium-sized and small-sized arteries. It's an acute necrotizing vasculitis involving medium and small-sized arteries. They may present with systemic features like fever, myalgia, anorexia, and general ill health. Specific manifestations depends upon the vessels involved. And in nearly 20% of the cases, testis and scrotum may be involved. Epididymis pain, testicular pain has been described in polyarteritis nodosa in nearly 20% of the cases. And significantly, polyarteritis nodosa does not involve the lungs and doesn't cause significant renal problem. Pulmonary involvement is rare because the pulmonary lungs contain small arterioles and capillaries and venues, and this is a medium-sized artery, doesn't involve significantly the lung parenchyma. But when bronchial arteries are involved, there can be lung infarctions. So the presentation would be much different than this case. Renal kidneys, when they're involved, hypertension is a commonest feature, and glomerulonephritis is unlikely in polyarteritis nodosa. And there is a significant association of development of polyarteritis nodosa with hepatitis B virus infection. So our patient had hepatitis B positivity, he had leukocytosis, high ESR, CRP, and ANCA was negative. Polyarteritis nodosa is ANCA negative vasculitis. Now, associating this patient under discussion, does it fit into PAN? He presented with systemic manifestations in the form of fever, non-specific musculoskeletal symptoms, then developed testicular pain and swelling, which went on increasing. He had a high WBC count, high inflammatory markers, and he had significant past history of hepatitis B virus infection, but there was no active hepatitis B virus disease. Generally, when polyarteritis nodosa occurs as a result of hepatitis B virus disease, hepatitis B is in active state in the form of significant positivity to HPSAG, hepatitis B, and usually the virus would be detected. Hepatitis B with DNA may be detected. So this is unlikely to be this is definitely not a case of active hepatitis B virus infection, because all the hepatitis B markers were negative except hepatitis B core antibody, which is positive, which suggests a remote infection. And though HBV also was negative, his AST, ANT were elevated, probably could be because of his alcohol intake, which was slightly higher than normal. But apart from that, when the HBV DNA is also negative, all hepatitis B markers are negative except core antibody that is not antigen, core antibody. I would like to exclude hepatitis B as a cause for PAN in this patient, but it's a coexisting finding. Lung shadows and few respiratory symptoms were present, but there was no significant lung involvement. The patient had cough, was evaluated few years back, but in a man who is smoker for 40 years, in a man who had healed tuberculosis in the apex, some symptoms of cough without active lesion may not be attributed to an ongoing process, because the lung shadows were stable over the years, even 3 years back and even in the present admission. And the sputum examination repeatedly was negative. And sputum and other infective causes were ruled out, especially in the lungs. Microscopic hematuria was seen, but no RBC causes or proteinuria, suggesting no significant renal involvement, but some amount of renal involvement, or hematuria may sometimes happen because of epididymitis also. Extensive workup for negative infectious diseases were negative, pointing towards the possibility of inflammatory condition like vasculitis in this patient. So most of the things correlate with this clinical presentation. So what would you think of the diagnosis in this patient? Can we describe with the help of a single entity to explain all, or should we go for different unrelated entities? Do we take the Occam's razor or Hickham's dictum? Occam's razor says, as popularized by William Osler, says, a single condition can explain all the patient's problem. As far as possible, we should try to make a single diagnosis which explains the patient's problem. Hickham's razor on the dictum, on the contrary, says that patients can have as many conditions as they like. So it's not necessary to put everything under one diagnosis. So I am tempted towards to make two diagnoses. Again, I quote from William Osler. He says, medicine is a science of uncertainty and an art of probability. I have considered so many possibilities and reasonably excluded many of them, included some of them, and considering all the probability, and it's definitely a science of uncertainty. Of course, after the discussion, if the case turns out to be a testicular lymphoma, we are not surprised because medicine is always a science of uncertainty. There is no hard and fast rule where we can say that, no, this cannot be this. This is tuberculosis or this is vasculitis. So my diagnosis goes towards two reasons. First, if I go by to explain everything, the easy diagnosis which comes to my mind is tuberculosis, because the patient had pulmonary tuberculosis, he had high ESR, high epidermolysis, cultures are negative, which can happen with renal tuberculosis. But however, I would like to go little away and point towards a different cause, because I am not convinced that with just short duration, patient having such a severe inflammation with the short presentation, there is no rule that if they had pulmonary tuberculosis earlier, all subsequent illness should be attributed to pulmonary tuberculosis. So I would go by the Hickham's dictum, and I would consider the possibility of polyarteritis nodosa, which reasonably explains most of the conditions like testicular involvement, inflammatory condition, presenting with epidermolysis, old pulmonary tuberculosis, which was heat, remote HBV infection, no active disease. One thing which is which I have not explained so far is the positivity of anti-nuclear antibody. ANA was positive in 1 in 40 titers. 1 in 40 titers, it said that at least 30%, nearly 25 to 30% of the normal individuals may have positive ANA at 1 in 40 dilution. But even at 160 dilution, 5% of the individuals may have ANA positivity. Sometimes even vasculitis may have ANA positivity. None of the other markers were tested, or of the like anti-double strand DNA. The patient did not have any other clue towards any other rheumatological disease. So I would consider that ANA positivity as possibly unrelated to the present problem. So whether it's a past history of tuberculosis and HBV is significant in this patient, if it is turned out to be polyarteritis nodosa, yes. Because if it turns out to be polyarteritis nodosa or any other vasculitis which might require usage of immunosuppressant drug, the history of tuberculosis and past history of hepatitis B infection becomes important, because there is a possibility of reactivation of tuberculosis and reactivation of hepatitis B are expected problems. In that context, both these conditions and all the three diagnoses in this patient, like PAN, old pulmonary tuberculosis, and remote HBV infection, are important. And the diagnostic procedure I would recommend in this case would be to get a final diagnosis, of course, epidermal or testicular biopsy. We can do some non-invasive tests like arteriogram, which may not give complete picture and which falls short of giving the final diagnosis. So probably the diagnostic procedure done in this case would have been a testicular biopsy or epidermal biopsy. Some investigations like probably urine for CBNAT would have been helpful to detect renal tuberculosis or genitourinary tuberculosis that could have been done in this patient. With this, I conclude my presentation and discussion and wait for the final diagnosis from Madam.
So excellent discussion, Dr. Shrikant. And as we tell, journey is more important than the destination. Destination is our diagnosis, but the journey what you have took us all along, discussing different aspects how these patients can be analyzed. That is very, very interesting, informative. I thank you for that. And meanwhile, if any of the delegates have got posted any suggestions, any diagnosis, or panelists want to put their thought before Madam tells her a diagnosis, tells her this one, I welcome panelists if anybody has got a comment for this. And meanwhile, somebody comes in, I just want to ask whether you wanted to discuss any amyloidosis as a possibility in this patient. Patient had tuberculosis in the past, and suggestive of bronchiectasis in this patient were there, and it could be a multi-organ presentation, amyloid.
Yeah, amyloidosis of testis. Generally, when amyloidosis happens following tuberculosis, it happens in the area where there is lesion, like lung. So clinically, there is, for example, if the patient were to have, then probably would have high proteinuria. Then that is the most important thing where we can make a diagnosis. High proteinuria, nephrotic syndrome like picture. And because the pulmonary involvements are quite stable, there is nothing to suggest an ongoing process, either tuberculosis or amyloidosis. So the symptoms are not ongoing, the lesions are not ongoing. So I do not consider, and amyloidosis is a part of paraproteinemia, of course, is definitely ruled out because of negative SPEP and other clinical features.
Okay. Dr. Krishna Kumar, any delegates have posted any questions to Dr. Srikanth
Professor
Hegde before
Narasimha has
Madam
raised their hands.
I will add one.
Sir, Maya sir, you wanted to tell something?
I think it's a difficult case, but I think as a guess, because liver is involved, lung is involved, past involved, present doesn't matter. Liver is also multiple things are there. Lung showed two shadows, and kidney is involved. I would think of discuss about sarcoidosis possibility. Sarcoidosis.
I'm Dr. Narasimha. Sir, ANA positive, hematuria, liver involved, arthritis, we have to consider SLE, so we cannot negate SLE. I want other information, double-strand DNA complements. Because
complements are normal, sir. In this patient, complements are normal.
Could be normal. So if it is low, it is helpful. Normal doesn't helpful. Hematuria, we have to explain.
Hematuria 10 to 20 are no albuminuria.
Among the proteinuria means according to WHO class 1, 2, 3, 4, and class 3 and 4, they will be proteinuria. Nephrotic proteinuria class 5.
Oh.
Class 4, there will be mild proteinuria. Class 2, no proteinuria. And nephrosclerotic variety, there no proteinuria. Sir. Only hematuria could be there. The varied manifestation, renal manifestation, because secondary vasculitis of SLE, testicle can involve, and SLE can cause secondary vasculitis and lymphangitis also. Lymphangitis and secondary vasculitis in SLE very probably. However, palliative node is the most common involvement of testicular pain. But sir, one more condition I want to say, what about filariasis? It's so endemic. We used to see a lot of portal elephantiasis, but testis involvement is a bit rare in that. But filariasis
involvement, lower limb involvement is not there. Eosinophilia, especially the patient had normal eosinophil count.
We used to see as undergraduate a lot of elephantiasis of leg and only filariasis of scrotum used to see. Now it's become a rare. And sarcoidosis is a bit unlikely here because kidney sarcoid not that common. And the second, one more possible antibody syndrome, sir, where thrombotic events in the testis can cause pain. Antipospholipid antibody syndrome also one of possibility. I would like to know PT, APTT, and antipospholipid
PT was 1.4. APTT was not mentioned, sir.
APTT will be prolonged. PT will be normal.
Not mentioned.
And lupus anticoagulants will be positive antiphospholipid antibody syndrome. It could
lupus
be primary.
Anticoagulants also not mentioned. Only rheumatoid and anti-CCP and cover mentioned.
And hepatitis B will be an antigen which is responsible triggering autoimmunity in microscopic polyangiitis and palliative nodular. Active infection will not be there, sir. Thank you.
No,
Thank you.
Hepatitis B surface antigen was also negative, sir.
Negative.
Surface antigen was also negative. Surface antibodies were also negative. Only core antibodies, HPC core antibodies were positive.
It is only antigen of the hepatitis C and B which is responsible, not active infection. Whatever the marker of the virus, the antigen of the hepatitis B or C in the body, it triggers autoimmunity of palliative nodosa. May not be active infection.
Yes, sir.
Dr. Krishna Kumar,
it was a very good discussion, sir. I enjoyed your discussion.
Thank you, sir.
Yes, sir.
Krishna Kumar, anybody has made any diagnosis or any questions to Dr. Srikanth Hegde in the delegates? If nothing is there, we will ask Professor Vijaya to present us the findings. Anything is there?
I'm not able to see anything right now. I'll just check in a back.
Okay. Madam, please tell your findings, madam. I welcome Dr. Vijaya to tell the final diagnosis.
Good afternoon. At the outset, I thank Nagraj sir and team for giving me this opportunity and asking for a fever to be the primary symptom. And I congratulate and appreciate greatly Dr. Srikanth sir. It was a wonderful discussion, methodically went step by step and ultimately coming to the final diagnosis. And you have not left anything for me except for me to show the histopathological pictures. You've done everything. You've discussed the whole differential diagnosis of vasculitis. And I don't think I have a role here now after hearing to sir's discussion. I'll share the screen, sir. Sir, is it visible, sir? Share the screen?
No, madam. No.
Yes, now, yes, ma'am.
Now it
Yes.
is visible, madam.
Sir, is it visible, sir, the screen?
Yes, yes, madam. Yes.
So, sir, thanks, Shrikant, sir, for making my job easy. And of course, it's really very much negligible.
No, virtual conference. I talk to later.
Initially, they did a temporal artery biopsy because it was easily accessible. There was dense inflammatory infiltrate in the adventitia of the arterial wall and scattered inflammatory cells in the media and intima. And we usually do the VVG stain, which is a trichrome stain, to assess the integrity of the internal elastic lamina. And VVG stain showed focal disruption of elastic fibers in vascular intima. And IHC staining for CD3 and CD163 highlighted lymphocytes and histiocytes, respectively, in the inflammatory infiltrate. This is the HLD picture where we can appreciate the lymphohistiocytic infiltrate. The arrows are showing the lymphohistiocytic infiltrate in the adventitia, and you can see scattered inflammatory infiltrate in the media and in the intima. And this is the VVG stain, where we had to, if in a normal blood vessel, we had to see a beautiful internal elastic lamina at this region. But now there is, where the arrows are showing, we are seeing disruption of the internal elastic lamina, indicating injury of the blood vessel wall. And this is the IHC marker for CD3, which is showing in brown color these lymphocytes, predominantly in the adventitia and few in the intima. And this is CD163 to show the histiocytes as well. So the presence of a vascular lymphohistiocytic infiltrate and elastic fiber disruption, it supports a diagnosis of active arteritis. At this point, the differential diagnosis for medium to large vessel arteritis could be giant cell arteritis, polyarteritis nodosa, and ANCA-associated vasculitis. Since the inflammatory infiltrate was centered in the adventitia rather than the media, the diagnosis of PAN and ANCA-associated vasculitis were preferred than the giant cell arteritis, but just absence of giant cells will not rule out giant cell arteritis. So, as sir requested, epididymal biopsy and testicular biopsy was performed. Epididymal biopsy showed prominent inflammation surrounding small arteries in the fibrovascular stroma between unremarkable epididymal tubules. The blood vessels showed fibrinoid necrosis and mural infiltration by mixed inflammatory cells composed of neutrophils, lymphocytes, eosinophils, and histiocytes. We have this epididymal biopsy. These are the epididymal tubules. This one appears a little bit slightly enlarged. And these dotted lines, encircled dotted lines, show the blood vessels, which are showing fibrinoid necrosis in the lower one. And there is transmural inflammatory infiltrate at this magnification. Going to the higher magnification, we can observe in the blood vessel to the right, you can appreciate there is fibrinoid necrosis of the segmental fibrinoid necrosis of the blood vessel, where the arrowheads are pointing, and almost occlusion of the blood vessel also, lumen also. And there is transmural inflammatory infiltrate composed of lymphocytes, histiocytes, eosinophils, and neutrophils. Again, CD3 and CD163 was done to highlight the lymphocytes and the histiocytes in the blood vessel wall. And also testicular biopsy is also done, where you can see this is a normal seminiferous tubules, and these are the blood vessels. Arteries, small vessel, small size arteries, where you can see fibrinoid necrosis of the blood vessels, and the arrowheads are pointing for transmural inflammatory infiltrate. So collectively, these findings support a diagnosis of polyarteritis nodosa. So it's a systemic necrotizing vasculitis, first described in 1866 by Adolf Kussmaul and Rudolf Meyer. It typically affects medium-sized arterial vessels, but may affect small-sized arterial vessels also. PAN is not typically associated with anti-neutrophil cytoplasmic antibodies, as we saw in this case, ANCA was negative. In majority of the cases, etiology remains unknown, it is idiopathic. 1/3 of patients with PAN have chronic hepatitis B, which leads to formation of HBs-AG, HBs antibody complexes that deposit in affected blood vessels. Clinical manifestations result from ischemia and infarction of affected tissues and organs. The PAN is associated with segmental transmural necrotizing inflammation of small to medium-sized arteries, often with superimposed aneurysms and or thrombosis. Kidney, heart, liver, and GI tract vessels are involved in descending order of frequency. So impaired perfusion of parenchyma distal to the lesions results in ulcerations, infarcts, ischemic atrophy, or hemorrhage. And as we saw in these slides, during the acute phase, there is transmural inflammation of the arterial wall with a mixed inflammatory infiltrate of neutrophils, eosinophils, and mononuclear cells, frequently accompanied by fibrinoid necrosis and luminal thrombosis. So usually in histopathology, we have fibrinoid necrosis, whether it is segmental or completely involved in the blood vessel, to call it as vasculitis. Older lesions show fibrous thickening of the vessel wall extending into the adventitia. Characteristically, in PAN, all stages of activity from early to late coexist in different vessels or even within the same vessel, suggesting ongoing injury. As Sir discussed, it's primarily a disease of young adults but can occur in all age groups. The course is frequently remitting and episodic with long symptom-free individuals. Because the vascular involvement is widely scattered, the clinical and signs and symptoms of PAN can be quite variable. So as it's already discussed, the patient may develop abdominal pain and bloody stools caused by vascular gastrointestinal lesions, diffuse myalgias, peripheral neuritis, renal involvement. Immunosuppression can yield remissions or cure in 90% of the cases. So to conclude, we had small blood vessels of the testis and epididymis showing features of vasculitis. The temporal artery showed features of active arteritis, negative ANCAs, negative cryoglobulins, and negative results for infectious diseases. And even Neisseria and chlamydia were negative in urine. So the final diagnosis, which was really done on clinical discussion, is confirmed by histopathological examination of the testis and the epididymis as polyarteritis nodosa. So this is one thing we have to think. And of course, I think the testicular swelling was the one which really leads to a diagnosis of polyarteritis nodosa in this case. Thank you all for your kind attention.
Thank you, madam. Very nice discussion of your histopathological changes of this patient, and nicely it's given. And also, I thank you for this, and also I congratulate Dr. Shrikant Hegde for hitting the bullseye. Exact diagnosis. So congratulations, sir. Congratulations to you, madam. Thank you, and I hand over the mic to Dr. Krishna Kumar.
Thank you, sir. Thank you very much for the wonderful CPC discussion. Thank you, Nagaraj sir, for chairing the session. Shrikant sir, wonderful case. Thank you very much. I think lots of clinical pearls, differential diagnosis coming in there. Vijaya ma'am, thank you for the images. Thank you for the wonderful slides there. I think so we have audience more than diagnosis. They're all with the case and things. They're telling, sir, wonderful workup, a beautiful presentation. These are the comments which we are getting. Actually, they want the gist of this, sir. They wanted Shrikant sir asking, sir, do's and don'ts, how to approach the case, algorithms. They're asking for it. Maybe we'll write to Shrikant sir later and we'll send it them as a flyer to all the students. Shrikant sir, thank you very much. Vijay ma'am, thank you very much.
Krishna Kumar, small comment.
Yes, sir, please.
Excellent discussion, and histopathological also a very good workup was done. One comment: there was a thrombus intraarterially. Still, we need to rule out to secondary antiphospholipid antibody syndrome. So, getting APTT and antiphospholipid antibody, lupus antibody also required, because it makes the treatment little different. And other thing, even palate nodosa consider, because of the temporal artery involvement. We have to consider palate nodosa overlapping with temporal arteritis also more appropriate in this case. And one more thing I feel missing is palliative nodal always should go for angiogram, because the beaded appearance is one of the most specific feature of palliative nodal, which usually doesn't occur in other vasculitis. So angiogram of the renal arteries or the testicular arteries might help us both. Not only that, if you see aortogram, aorta is involved. Again, it is palliative nodal overlapping with the temporal arteritis or genital arteritis. We can further final refining of the diagnosis might have been helpful. Anyway, excellent discussion by Srikanth, and also Madam also histopathology, vessel biopsy given fair information. Some of work also required. Thank you.
Thank you.
Thank you, sir. Thank you, Narasimha sir. There. Thank you, Srikanth sir. Thank you, Vijay madam.
Dr. Nagraj, for giving me this opportunity. Thank you very much. Thank you.
Thank you, sir. Thank you. We move on to the next session. One more important session coming up there, which is a pro-con debate of FEFCON 2023, and this is the last session for FEFCON 2023 from the physicians all. This is a session on short course antibiotics versus the long course antibiotics. To chair this session, we have Dr. Sayan Chakraborty sir coming in there, and also to discuss on to debate on the short course, we have Dr. Haripriya Reddy joining in, and also to give the rebuttals and to tell what is a long course of antibiotics, we have Dr. Sunil Karan joining in there. To start with, let me have this opportunity to introduce Dr. Sayan Chakraborty sir. He is a consultant Department of Infectious Disease at AMRI Hospitals, Kolkata. He has lots of accolades academically. He has won lots of medals. He has published multiple papers across various journals, speaker in various conferences and symposiums, has experience of conducting many conferences. Thank you, sir. Thank you for joining in there. And it's